Hello everybody and welcome to my webinar. Today we're going to discuss a very interesting case. It's about a case of an extraction in the anterior zone of two teeth. This patient came to my clinic and has two severe periapical lesions with lots of bone loss. The patient sent to an endodontist in order to check the two teeth at 11 and 12. And you could see there is a massive radiolucency in the apex of the teeth. The endodontist discovered she has a microfractures, and those teeth could not be saved through endodontal treatment. And the more we keep those teeth, the more bone going to be lost in the anterior zone. So the decision was to extract these teeth, build a bone in the area where there is a bone loss, and to wait for 4 to 5 months and then to make the implants. Now, in this specific case, I'm going also to transplant the tissue, not just to make a bone augmentation, but also to do some tissue augmentation in order not to lose tissue in the anterior zone. The more we wait, the more bone going to loss in that area. This is why we have to make it as soon as possible. So we scan the teeth and we make a CBCT in order to see how the teeth should be aligned. And the patient, of course, will not get out of the clinic without having some substitute teeth in that area. And here we prepare from advance the Maryland bridge, which will be cemented to the adjacent teeth. I'm going to use luxator to extract the teeth in order not to lose bone and to make it as extraction as smooth as possible. It's very important to disconnect first the tissue from the teeth in order not to pull out tissues, because we need to have this extraction without traumatizing the tissue and to leave the papilla without harm. So here I'm using the tools and I'm releasing slowly the teeth with a little bit of rotation from side to side. And you have to feel it and not to pull straight away, just to make first the release, and then you can take it out. So this was tooth 12. Now we are going for tooth number 11. Again, rotation, a little bit from side to side, and then you can take it and pull it. Yes, slowly. So you could see there is no bone attached to the root surface. That means the bone that was surrounding the tooth stayed in the area, and now I'm making sure to take all the granulation tissue out of the socket. So there is a huge amount of granulation tissue in the apex of this area, and what we could see on the CBCT, and you can also feel it when we are taking out, when I took out the granulation tissue, that it's also stayed under the septum, under the interproximal septum between the teeth. One of the most important here, you could see the inflamed granulation tissue with some materials. You could see the endomaterials that came out with that. It's very important to take everything out, otherwise no bone regeneration will occur in the future, because this is inflamed granulation tissue. It won't help. If we won't take it out, the bone will not regenerate. So here you could see that there is a connection between 11 to 12 under the interproximal septum. So when I'm going to prepare the bone augmentation, it has to be also under the interproximal septum. I used here Max graft, which is an allograft from Botis. It's a cancellosed granules. I also mixed it with cross-linked hyaluronic acid. There is documentation and research that showed that when you use the cross-linked hyaluronic acid with a bone substitute, we could see more osteoclast and osteocyte built in that area. And there is bone regeneration occur faster. So here I'm mixing it together with saline and cross-linked hyaluronic acid. I also added xenograft. The xenograft itself helps us to have a matrix. This bone substitute will help us to keep the area with the higher volume, because xenograft degrades slower than allograft. And there is research that show that also when you add cross-linked hyaluronic acid to xenograft, we will see a faster bone formation. So I'm making sure that the bone substitute is inserted into the socket, and I'm condensing it. I'm taking the pad gas, and this will help us to make sure to condense the bone correctly. There was a huge bone defect in the apex, so it's very, very important to insert the bone to all the gaps in that area. I'm using this tool, which is Straumann tool. It also helps me to condense because this area is flat. There is in this scale, there is a flat area that helps to condense the bone for me. So I'm using it a lot as well. So this bone is a mix of xenograft, 20% xenograft and 80% allograft. I always use more allograft than xenograft in order for the bone to regenerate faster. You could see the papilla is intact. So in my surgeries, I always try to keep it as simple as possible and not to open flap in the extraction site. Opening flap during extraction site will cause to recession on the adjacent teeth and also to the bone on the extraction site it can get lost because of the opening. So better to keep the tissue surround the extraction site. Now I'm measuring how much tissue I need for the tissue transplantation. I'm leaving the edges of the tissue without bone, so I can suture the tissue, the free gingival graft to that area. So here I'm measuring from where to where I'm going to take the tissues. It's come from the palate. Of course, before that I measured and see there is no periodontal pocket on that teeth, because if there is a periodontal pocket and I'm making those kind of incision close to the teeth, then a recession will occur on the palatal side. So make sure there is a healthy tissues on the palatal side and there is no pocket. So my decision here was to take a free gingival graft. I'm taking 15C blade and making around edges. I'm penetrating almost until the bone. I do leave connective tissue and the periosteum on the palate side so it can get healed faster. I'm changing my blades a lot, so I want to be always that the blades will be sharp. And I'm detaching the free gingival graft from the palate. It's important to leave enough connective tissue for the free gingival graft because the epithelium will disappear, and if the epithelium is not supported by enough connective tissue, then the free gingival graft will go through necrosis. So at least 4 millimeters of connective tissue will be advisable for not getting a necrosis on this transplant tissue. Now I'm taking a collagen cone from Botis and I'm pressing it in the area of the free gingival graft. I'm taking a nylon suture, 5-0 on 15 millimeter needle, reverse cutting needle. And I'm going to do some suspended sutures to keep the collagen cone in the area. So here you could see 2 sutures that keeps the collagen in the area, and it will also help us to reduce the bleeding. Now I'm taking a membrane. This is also from Botis. This membrane in the thicker one. And what I'm going to do is divide it to 2 and going to make circles in the area that it will transplant. It will come to the area of tooth 11 and 12. So I'm measuring, I know the diameters that I need to cut. The purpose to put a membrane above bone augmentation is well documented. This is a GBR procedure. If we don't put a membrane above bone augmentation, we can get the tissue inserted into the bone substitute, and then we will get a compromised bone augmentation. So one of the questions that I got from my colleagues that was in the room, and they asked me why not to put it under the papilla and make like a one connection of the membrane between the 2 sockets, between 11 and 12. Now there is no purpose to raise the papilla because once you detach the papilla from the bone, then we can have a problem. So better keep the papilla inside and not to touch it and not to raise it from the bone level. So here I'm compressing the membrane, and this will separate between the bone substitute and the tissue transplantation. And I'm taking the tissue that I harvested. It's enough for both sides. You could see the side of the palatine, and you can see the side of the connective tissue. The side of the connective tissue, we will see some remnants of capillaries. You could see those little blood on the connective tissue side. Then I'm see which is the best, how is the best to put it. And you can see that if you leave a 4 millimeter of connective tissue, minimum 4 millimeter, it will attach to the connective tissue that we have in the surrounded of after the bone extraction, we have a tissue, connective tissue that's surrounded in the socket. So we can connect by suturing the connective tissue to connective tissue. So here I'm using a PGA sutures. It's a resorbable suture. It's a 6-0, 11 millimeter suture. This is a Resorba suture. It's from Resorba, it's a PGA suture. The suture will stay for at least 3 weeks. I'm using a lot the PGA from Resorba sutures. I'm making sure that the knot of the suture will be flat, so it won't open. So I'm suturing it for 4 edges to make sure that the stability of the harvesting tissue, the harvested tissue will stay in the place. So 2 on the palatal side and 2 on the buccal side. And then we make it also on area number 12. So here you could see a picture before and after, before the extraction and after the extraction with the bone augmentation. You could see the high of the papilla area, the bone edges of the area of the interproximal, and the bone augmentation, which was a 20% xenograft and 80% allograft. 20% xenograft of Straumann and 80% allograft from Botis with cross-linked hyaluronic acid. So we will wait 5 months, and the next movie we will show how I made the implants in the 2 area, 12 and 11, with guided implants. I used the guided implants of Easy Neodent, Easy Guide from Neodent House. It's a very easy guided implant surgery that helps us to make it a very accurate implantation. So here we are 5 months after. You could see the bone augmentation. Here is the scanning after the extraction and the bone and tissue augmentation. We prepared everything from advance, of course. We scan the mouse. We prepare the guide itself, the easy guide. And we made sure to order from advance the implant that we're going to insert. Before that, I wanted to check the vitamin D of the patient itself. Botis Care developed a vitamin D check, a very easy check from the finger, like we checking for glucose for diabetic patients. Then we're mixing the blood with some material that check the vitamin D. Then we check it on the machine. And we could see the vitamin D, how much the patient has. Here, the patient has 7. She needs to have more than 30. Vitamin D was already been proven by research that it's very important for bone augmentation, for bone buildup in our body. And if there is a deficiency of vitamin D, that means we might risk the bone augmentation, or we might risk the healing process of the bone augmentation. So the patient was advised to take vitamin D, in that case, 4 sprays a day. So here you could see I'm taking out the Maryland. We could see the compression of the Maryland on 2 spots, 11 and 12. I'm going to make my cut on more to the palatal side, because I'm going to make a specific flap to help and extend the buccal area by taking connective tissue from the palatal and roll it in under the buccal flap. So I'm getting until almost the papilla, the central papilla. I'm not continue and not cutting the central papilla. If you cut the central papilla, you for sure going to eliminate it or getting even a recession on the adjacent teeth. This is why I'm leaving the papilla, the central papilla, in situ. Now I'm making sure to have a new blade, and I will cut in the palatal side under the epithelium. Make sure to leave some connective tissue under the epithelium. You can see I'm cutting under the epithelium. Do not leave just the epithelial layer, of course, because otherwise you will get some necrosis there. Now I'm doing this horizontal incision and vertical incision so I can raise the connective tissue from the palate. You could see it. And this is pedicle tissue. It's the most important tissue that you can use. It connects to the flap, and this is the blood supply for this pedicle. You could see I can insert it into the buccal and enlarge the buccal area, plus I will get it also into the interproximal to enlarge the papilla. So I'm scraping a remnant from the bone augmentation, because every bone substitute that was not getting to be augmented or not getting to be regenerated, it's better to take it out. So I scrape it out. I take the guide, the and I lay down on the teeth. Make sure the teeth are inside and it sits firmly. If it doesn't sit firmly, it's better not to use it, because that means it's not accurate. I see that the insertion of the sleeves is surrounded by bone and it's not out of the envelope of the bone. And then by the plan, we're going to use a 3.5 millimeter diameter of Neodent GM implants. I'm taking the remnant of the bone that I was just taking out of the socket. I always keep those keep the bone. This bone is autograft bone. And you can see I'm using the Easy Guide. It's a very simple way to use. The first one is just marking, and then the second one you already get into the length that you want to use. We're going to use 11.5 millimeter of length and 3.5 millimeter of diameter. So here is an X-ray. I always take X-ray to see that I'm on the right, that I'm right on the line and it's parallel to the adjacent teeth. Then I took another one. This is the plus. This is another burr in order, because if the bone is hard, you can make another to extend the socket area, to extend the osteotomy. So here is the implant. The implant itself is hydrated, and the hydration is important to keep this implant for making this implant going to be inserted, and this is a hydrated implant. The hydration is important to make this implant osteointegrate faster. It was proven by Straumann already for a long time. This is the active implant, and this is Neodent implant come in hydration as well to keep it sterile and to make the osteointegrated faster, because then the carbon layer do not have to be reduced. So in a normal implant, the implant has to take out the carbon layer and then the osteointegration happens. And here you don't have to do it because of that. This doesn't have to be happening because of the hydration of the implant. So we insert the implant. This is a Neodent implant, GM 3.5 over 11.5 millimeters. This implant is also an active implant, so we can insert, let's say we did 11.5 millimeter, I can also insert another 2 millimeter freehand into a bony hard envelope. So you could see we have a 32 to 35 Newton. You could see the implant inserted, and you could see also the X-ray, how the implant lay down parallelly. We prepare also the crowns from advance and the abutments. This is a temporary abutments, which I'm going to cement inside the tooth, but it's going to be screwed retained. So the Omnivac that lays over the crowns will help us to orientate the crowns. So you could see here we have these temporary abutments. The papilla on the both sides, still the central papilla is in situ, so I didn't cut it, it stayed there. And now, after I cemented the crown, there is an opening on the palatal side, so when she will come in 2 till 4 months, I can actually screw it out. And I will take from the tissue and insert it into the interproximal side to build up more papilla. You see the autograft bone that I scraped, that I took out, sorry, from the osteotomy while I did the implant. and I'm inserted it back into place. This is an autograft bone, so I'm actually very happy to have it. And although it can, let's say, it can degrade faster, but it can also attach to the tissue aside without any harm. So here I'm cutting a bit from the tissue, releasing a bit more tissue so I can insert it interproximally. So here I'm taking, again, PGA sutures from Resorba. Take the connective tissue, one edge, attach it to the palatal side, and take another edge, and squeeze it in the interproximal side. It's a 6-0 suture. So this is one to the interproximal side, and then between the two crowns. So again, the same technique, taking the connective tissue through the palatal and suture it now on the palatal side. When you are using PGA sutures, it's very easy, so you don't have to take care too much of taking them out, or the patient can go for longer time, so you don't have to be concerned about it. Now here what I'm doing, because there was some tissue that was with little granules from the bone augmentation, plus I could see a little bit like irregular formation of the tissue, I went with the blade and get until the almost connective tissue, so the new epithelial layer will be built and will be looking nicer. It will renew the cells. So now I'm suturing the epithelial layer into the interproximal sides. So here you can see the suturing after the treatment. And the abutment with, of course, there is temporary crown that we cannot see, and the two implants. Here is the whole process, the bone augmentation. Then I took picture of the implants process itself, from the beginning till the end. Taking an X-rays can help you always to orientate yourself and know that you are on the right side and you parallel to the tooth. And if there is some mistakes, you can correct it on time and not to wait too long, or to wait after the implant insertion and then you realize you have to correct stuff. You do it step by step. This is how you avoid problems in the future. So thank you very much for coming to this kind of webinar and to my lectures. It was very nice to host you all, and I'm welcoming any questions you have. And I do recommend to use EasyGuide to help you insert the implant on the right way. Thank you very much.